So, good evening. Welcome to this sixth lesson in which we will talk about loneliness and social inclusion and social connection. A nice way to start the evening is to listen to a song. This masterpiece, written for the Beatles by Paul McCartney, masterfully interpreted by Ray Charles, brought to the forefront for the first time in the pop music the theme of loneliness. And it was really a shock. Eleanor and Father Mackenzie are two lonely people whose life crossed paths every day, but who were too busy hiding the despair and anguish to ever connect and find comfort each other. And so, from simple characters in a story, told in over 2 minutes, they become a metaphor of all human beings who walk side by side every day, unaware that perhaps a single word would be enough to escape the frightening ghost that is loneliness, and to avoid being among all those lonely people. No Man is an Island is a meditation by John Donne, a London poet who lived between 15th and 16th century. The last line you can read was taken by Ernest Hemingway for the title of his famous novel, For Whom the Bell Tolls. And is an authoritative invitation not to distance oneself from the affairs of others, but to consider oneself part of a whole. According to the National Agency Aging Monitor, one in four people over the age of 55 in Switzerland suffers from loneliness. This corresponds around 400,000 people. And loneliness, as our speaker of the evening will explain, should not be confused with being alone. The condition of being alone is not necessarily associated with suffering. Being alone sometimes can also be nice. Loneliness, on the other hand, implies a social isolation that causes suffering. One feels the lack of sharing with others and participating in social life. In the medical field, if we go to the main medical database PubMed and type loneliness, more than 18,000 citations will come up. But which is really striking is the exponential growth that we saw in the last probably 10 years or even less. And so this is a sign that the issue of loneliness is emerging in a pervasive way in the medical field. So much that Suzette, as I mentioned it in the first evening, talking about social determinants, in the United Kingdom and in Japan, they felt the need to create a ministry of loneliness. And in countries like Germany and the Netherlands, they have begun to treat isolation as a public health issue. Tonight we have with us one of the world's leading experts on loneliness and social inclusion, Julianne Holt-Lunstadt. And after her, who I will present just now, and after her, a very special family doctor, who's sitting here, Cristiano Figueiredo from Lisbon will give us a very valuable account of the creation of one of the first European models of social prescribing after United Kingdom. So now I will present the main speaker of this evening. Julianne Holt-Lunstadt, PhD, is a professor of psychology and neuroscience and director of the Social Connection and Health Lab at Brigham Young University. She is also scientific chair and board member of the US Foundation for Social Connection and the Global Initiative on Loneliness and Connection. She was the first researcher to publish a study connecting poor social support to deteriorating health and death, premature death. Her research focuses on the long-term health effect of social connection and includes a meta-analysis of the effect of loneliness and social isolation on mortality. She has given TED Talks and has provided international consulting and expert testimony to many organizations, including serving as lead scientific editor for the US Surgeon General Advisory and Framework for a National Strategy. So, dear Professor Holt-Lunstadt, dear Julianne, we are all eager to listen to your presentation. So please, now you have the floor.
Thank you so much. I'll go ahead and share my slides. Well, thank you so much for inviting me to speak to you all about this incredibly important topic. Before I begin, I just want to acknowledge that, of course, all the work that I'm going to be sharing with you today was not done in isolation. So I want to acknowledge and express gratitude to the many people who contributed to this work, the many who informed this work, and those who supported this work. I want to just start by asking you all to pull out your phone, and I'm not going to ask you to turn it off. I actually want you to open your photo app, and I want you to just quickly scroll for a moment and find a picture that truly just brings you joy, or maybe even makes you laugh out loud. Just take a minute or just a few seconds. Hopefully it shouldn't take you long. Now, if we had more time, I would ask you, and maybe perhaps later you can share these with each other. But when I do this with various groups, what I find is that over and over again, the photos that you share are of those people, that you care about. And this is not surprising because we see study after study shows that when people are asked, what is the key to happiness? We consistently find that it is not wealth or success, it's actually our relationships. It's our close relationships with family, friends, and others. But these are our relationships that bring us joy. So it's perhaps not surprising that one of the truisms in life is that people often don't appreciate what truly matters until it's gone. And so it's clear that the global pandemic brought greater awareness of the importance of social connection for our well-being. But of course, this is not a new concern. This is something that we have evidence on, and that was growing well before the pandemic. but this has certainly brought greater awareness. The pandemic also revealed how social connection or lacking connection can have ripple effects, not only influencing us personally, but nearly every aspect of society. In fact, building connection is incredibly critical. And so while there are concerns of a loneliness epidemic, we're also facing several societal crises, including climate, mental health, violence, addiction, and other types of crises. And social connection or social disconnection, I should say, may be at the root of all of these crises. Now, on the flip side, we're also seeing a growing number or a growing trend of interest in living past 100. We see companies developing products and services to a Netflix docuseries on how to live to 100. And so increasingly, we're seeing the desire to push the boundary of human potential and survival. But of course, we don't want to just simply grow old. We want to actually thrive. And so here I show an example of a 101-year-old skier from my state in the US. And so this really illustrates the distinction between lifespan and health span. And importantly, social connection is critical to both lifespan and health span. And indeed, while of course there are many factors that influence well-being, we're seeing that the OECD framework for well-being now includes social connection as identified as a key indicator of well-being. So in the remainder of my remarks today, I'm going to really talk about what do societal trends show us about, and what do we know about how connected or disconnected we are? How do we define this issue? What are the consequences? And of course, what are the implications for action? So let's first start by looking at what some of the trends tell us about this state of social connection. If we look at some global data, this is data from the Meta-Gallup Global State of Connection Survey that has data on 142 countries worldwide. And what it reveals is that nearly a quarter of the global population feels very or fairly lonely. And that this is particularly high among young people. But we also saw that from this map, that there's variability across countries. And so of the 29 countries where at least a third of the population felt lonely, 22 were in Africa, 4 were in the Middle East, and 3 were in South Asia. So this also demonstrates that this isn't just a European or wealthy nation issue, and that truly this is a global issue. Now, of course, we know loneliness is important, but it isn't the whole picture. Now, this is data from the US, but there's certainly data from other areas as well. But interestingly, this shows that, while there's the perception that isolation and loneliness are a result of the pandemic, when we look at trends that come before the pandemic, this is from the American Time Use Survey. It tracks how people use the minutes of their day. And what we see is that there was increase in social isolation, decreases in time spent with household and non-household family, decreases in time spent with friends, time spent with others, and time spent in companionship. And so what this suggests is that some of these trends, at least in terms of the time spent with others, were declining well before the pandemic. And there's also data that dates back even decades earlier demonstrating declines in social capital. Now, if we look at the OECD data that was just released just about a month ago, this shows changes over the last roughly decade. Depending on the indicator, the years vary, but what this suggests is that getting together with friends has declined. Getting together with family has declined. Interestingly and not surprisingly, remote contact is up, and loneliness has remained stable. Now, if we look at other kinds of trends, this is for Google searches on how to make friends. And these types of searches are at an all-time high. And so this has a number of implications. What it suggests is that, yes, while there are indicators that there's an increase, or that there's a significant portion of the population that's lonely, what it suggests is that we're actually disconnected in a variety of ways, not just loneliness. And that all of these forms of connection are critically important and may be at the root of several of our societal crises. And so it's important to take all of them seriously. So because we hear mostly about loneliness, let's talk about what that really means. Because oftentimes it's in kind of informal or colloquial use, it's used as a catch-all term for all forms of lacking connection. But in science, it actually refers to something far more specific. And so as highlighted earlier, it is different. Social isolation and loneliness are related, but they're different. So social isolation is objectively being alone, having few relationships, or infrequent social contact. It's a bit more objective. Whereas loneliness is more subjective, feeling alone, and it's a distressing feeling. And this is the discrepancy between one's desired level of connection and one's actual level of connection. Both, of course, isolation can increase one's risk for loneliness. So objectively being alone increases your risk of feeling alone, but you can be alone and not feel lonely. And conversely, you may you can be alone and not feel lonely, and you can be surrounded by others, but still feel lonely. Now, what I want to emphasize is that both isolation and loneliness have been linked to poorer outcomes. And so even if you are only one or the other, both carry risks. So how does this fit into social connection? Social connection is thought to be a catch-all term. This is more of an umbrella term that encompasses the key components that have been linked to health and other kinds of important outcomes. And so these three key elements are the structure, function, and quality. So the structure refers to some of those more objective things, including the number and variety of relationships and interactions. And so, of course, low structure, isolation fits squarely under that pillar. But we know that simply having people in our lives, while important, is not sufficient. And so we also look at the function, the degree to which relationships serve various needs and goals. And so that can be represented by low social support, but also could be represented by loneliness. And And then quality is also important. So even if we have people in our lives and people that we can rely upon, if that quality is not high, so perhaps there's negativity in that, it could be strain, conflict, or unreliability. We want to make sure that that these are high quality. So when structure, function, and quality are high, this is associated with protective effects. And when any one of those is low, it's associated with risk. So again, isolation fits more under low levels of structure. Loneliness fits more under low levels of function. And negativity falls under low quality. It's also important to recognize that this is more than just about relationships, and that we have data to suggest that relationships with family, friends, and close relationships are really important, but also so are the relationships within our communities, relationships with coworkers and supervisors, and even our relationships with what are called weak ties, often with acquaintances or even strangers. So the implications for all of this is that when we are measuring social connection, it needs to be multifactorial. It cannot just be loneliness. Loneliness only covers low levels of function, not the full gamut. So we do need multifactorial assessments. Also, we need to emphasize the positive and the protective aspects of social connection, and not just focus on the deficits. And that really is tied to the World Health Organization's definition of health. This has been in their constitution since the 1940s, which states that health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So again, unfortunately, while the social well-being has not received as much attention, we're starting to see more and more attention on that, but also emphasizing the last part of this, that we do need to look at not just alleviating some kind of infirmity, but rather that we are helping people to become resilient and to actually thrive. So why is this all so important? We have found that social connection is often underappreciated. It's viewed as perhaps nice to have, but not as essential. And yet social connection, the data is quite clear that it is critical for individual and population health, well-being, community safety, resiliency, and prosperity. However, far too often people lack connection in one or more ways, compromising these benefits and leading to poor health and other negative outcomes. And so when we think about the distress and that we often feel that is associated with loneliness, it's because humans are social beings and we are not meant to be alone. And so we see that across a number of species that being socially connected to a group serves important functions, whether it's direction to safety, evading predators, comfort and protection from the elements, reciprocal altruism, obtaining food. Being part of a group is essential to survival. We see that social connection is, and this is widely viewed across many scientific disciplines, that social connection is viewed as a fundamental human need. And that's because throughout human history, we have needed others for survival. And so we can think of loneliness as a biological symptom akin to hunger or thirst. And so just like hunger motivates us to meet nutritional biological needs and motivates us to seek out food, loneliness motivates us to seek out social connection. And so if we extend this analogy, isolation would be the objective lack. So objective lacking social connection. And if we take the analogy even farther, just like food and water are essential to survival, food can spoil and water can be unclean. And similarly, when it comes to social connection, we need high quality, and that lacking high quality can actually potentially carry risk. And so since social contact is essential to survival, social homeostasis is a way of regulating and maintaining social structures and interactions. And when social contact is perceived as insufficient, loneliness motivates reconnection. It can reestablish this equilibrium. However, in the long term, if social needs are not met, a new equilibrium can be established. And so if this is sustained over time, this can lead to dysregulation of multiple biological systems that puts us at risk for disease. And from a behavioral standpoint, this can also lead us to become more self-protective, including things like antisocial behavior. So how do we see this showing up? Well, in my own work examining mortality risk, we gathered all of the available data globally, including population data on over 3.4 million participants. Among initially healthy people tracked over time, those who experience social deficits are more likely to die earlier regardless of cause of death. So more specifically, loneliness is associated with an increased risk of earlier death by 26%, isolation by 29%, and living alone by 32%. Now, another recent meta-analysis replicated these findings, this time with 2.2 million people and 90 studies. And so what it found was that both isolation and loneliness were significant predictors. But this newer data suggests that social isolation is a significantly stronger predictor than loneliness. So again, we don't want to dismiss objective isolation given it has stronger implications for mortality risk. Conversely now, in an earlier meta-analysis of 148 studies examining the protective effects of being socially connected, we found that social connection increases odds of survival by 50%. So this protective effect is actually significantly even stronger. So how do we put this all into perspective and understand just how serious we should be taking these things? So my colleagues and I took the effect sizes of the various indicators of social connection, which are represented in the orange bars, and compared it to some of the leading health indicators, which are represented in the blue bars. This includes things like smoking, alcohol consumption, physical activity, obesity, air pollution. And of course, we inversed relevant ones to ensure that they were all in the right direction. But what we can see is that these indicators of social connection are, although they may vary in their magnitude, they are on par with all of these other leading indicators of health. And so what that suggests is that we need to be taking social connections just as seriously. And I'll also indicate that this evidence goes beyond deaths of despair. This is all mortality from all causes. And the evidence goes beyond loneliness. And so we need to consider all forms of lacking connection. Now, the mortality findings are also consistent with evidence that social connection influences a variety of health outcomes, including physical health, which includes things like cardiovascular disease, stroke, type 2 diabetes, mental and behavioral health outcomes, including depression, anxiety, suicidality, and addiction. It also includes cognitive health outcomes, including cognitive decline, dementia, including Alzheimer's disease. It even includes economic health outcomes. And various studies are now showing the health costs and other indicators. So, for instance, workplace absenteeism, productivity, and lower quality of work, all leading to health, to economic implications of this. We also have evidence of how social connection leads to poorer health and mortality through psychological, biological, and behavioral pathways. And so these aren't just interesting correlations. We have good evidence of these mechanisms, including biological mechanisms that account for these effects. We also have good evidence that social connection is not just important for individuals, but have powerful influences on communities. And so this is also a societal issue. So, for example, these range from population health to community safety, resilience, prosperity, and representative government, while lower levels of social connection suggest worse outcomes in each of these areas. So, for example, several studies document the importance of social connection in times of crises. So not just personal crises such as losing a job, but to community crises, including natural disasters, floods, fires, earthquakes, heat waves, pandemics, war. Among these, the ability to mobilize resources via one's social connections can often be a matter of life and death. Communities where people know each other are better prepared for, respond to, and recover more quickly from natural hazards than those with lower levels of social connection. We also see how social isolation and inequity are contributing to increasing rates of distrust. So, as I mentioned, when we are isolated, we often behave in defensive ways and need to be more vigilant to threats in our environment. And this may contribute to distrust in others, including distrust in our institutions, as well as those in our community. We also see how, as our social networks become more homogenized and only interacting with people similar to ourselves, that this is associated with greater political polarization. And we see how isolation is contributing to other kinds of issues. So, for example, because social connection is such a fundamental human need, we often may seek it out in unhealthy ways. And this may contribute to wanting to be part of finding meaning and belonging, which can increase one's risk for radicalization and extremism that can ultimately lead to targeted violence and even terrorism. So what we see is that social connection may be the key to understanding and addressing not only individual, but societal issues, and the key to thriving. But we need solutions. And unfortunately, we also understand that there are a number of challenges. So what do we know about the effectiveness of interventions? There are now several systematic reviews and meta-analyses looking at this. But as I mentioned, we can be disconnected in a variety of ways, all of which can contribute to this. However, the majority of these reviews are focused almost entirely on loneliness, with fewer on isolation and even fewer on poor quality relationships. And these are also almost entirely focused just on individual level kinds of interventions and few on intervening at the community level or at the societal level. The majority of these are also focused on older adults, and many of them, the evidence quality was low. But despite these limitations, what this evidence suggests is that many of these are indeed show some success, small to moderate effects, but we ought to make sure that we pay attention to these limitations. Now, another challenge of this is that some of these solutions, because they may only be focused on loneliness, they may be focused primarily on focusing on individual preferences. And so we need to be careful about differentiating between hedonic kinds of individual preferences, because what might bring you pleasure in the moment may not always be healthy long term. So of course we have analogous examples of this in terms of foods and other kinds of behaviors that may bring us pleasure in the moment but are not healthy for us long term. So we need to be very careful about those that may stimulate reward centers or dull the pain without actually addressing the underlying cause. So it's important to also take into account that we have evidence that it takes an average of 17 years for evidence to get put into practice. So of course we want solutions quicker, but the reason for it taking so long is that new treatments, and this is any kind of treatment, not just isolation and loneliness, but any kind of treatment, 95% of the time they fail. So we can't just assume that everything that's social is going to be effective. We actually need to evaluate it and make sure that it is effective. So we need to also need to shift to more of a holistic kind of approach. So going beyond the individual, if we look at a whole of society approach, what I'm presenting here is the 6 pillars to advance social connection that I and my colleagues put forth in the U.S. Surgeon General's advisory. And while this, of course, was focused on the U.S., we actually drew upon global policy recommendations, existing global recommendations from consensus reports to establish these. So there may be relevance more at a more global level as well. So just briefly, I'll just highlight what these 6 pillars entail. They include strengthening the social infrastructure in local communities. And what I mean by this is strengthening and enabling the places and spaces where people can gather and socialize, and where social connection can emerge organically. And so this includes investing in the institutions that can bring people together. The second is to enact pro-social public policies. So much like we have, there's the health and all policy approach, where we recognize that all policies have health implications, and just like we would evaluate policies for their economic implications or their environmental implications, we need to evaluate all our policies for their social implications, and identify those and revise those that might be barriers to connection, and identify opportunities to strengthen communication. The third is to mobilize the health sector, and I believe this is probably most relevant to this audience today, and that is that we widely recognize the robust evidence of the health implications, and so we need to provide the kinds of resources and training to help the healthcare sector address this, and to expand the kinds of interventions that are within it. But related to this is, and to all of these is pillar number 4, and that is reforming digital environments. We recognize that not only are we rapidly changing the way in which we are socially interacting, and that this is often digitally mediated, but many of our interventions are digitally mediated as well. And so we need to really be careful and identify where these have equivalencies, where they may be helpful, and importantly, identifying where they may be sources of harm, and implementing safeguards where appropriate. The 5th pillar is deepening our knowledge. And so while we have robust evidence, we certainly, there are certainly still some gaps. And so we need to invest in evaluating everything that we do so that we have evidence in terms of what works and what doesn't. But we also need to increase public awareness, because we do know a lot. We have a lot of evidence that has not fully percolated into public awareness. And so we need to increase our education efforts as well, because we cannot change until we're aware of what needs to change. And then finally, the 6th pillar is that we need to build a culture of connection. And that includes cultivating values of kindness, respect, service, and commitment to others. And so even if we, build infrastructure, create policy, educate people, if it's not in line with the norms and values of our communities and our society, folks will not, this will not be effective. And so how do we build that connection? How do we change norms? We need to start modeling connection values in our everyday lives, and in our positions of leadership and within positions of influence. So I want to share with you a framework that I think can be helpful in helping us think about all the ways in which we can integrate this. And so this is the social connection framework. So social is a acronym for systemic framework of cross-sector integration and action across the lifespan. And so it starts with the individual and recognizes that the individual is embedded within relationships, communities, organizations, and society. And so if should look familiar to you, because this is the socioecological model. And so this framework builds on this existing model, but goes beyond it and extends by overlaying every sector of society. And it recognizes that social connection is relevant. And then certainly we saw that firsthand during the pandemic, when lacking connection influenced each and every one of these sectors. And so we need to account for how it's relevant to all of these sectors. But we also need to build on that by recognizing that each sector doesn't need to work in isolation, and that there's opportunities for collaboration across these sectors. We also need to recognize that this is relevant across modalities, across the lifespan, that we need to consider equity and access in all that we do, and that we need evidence across all of this. So because this past figure, it gets very, very complicated, to make it very simple, I put this in a grid where each column represents the levels of the socio-ecological model, and each row represents a sector of society. And thus each cell represents an opportunity for solutions. And so by numbering them here, this helps us systematically identify areas of our opportunity and gaps in efforts. And what's unfortunate is that most of what we have done so far, unfortunately, seems to be primarily focused within one of these cells. That doesn't mean that there aren't efforts across all of these, but the bulk of both the evidence and where our interventions are within that. And so what this suggests is that that there's 95% of this is untapped opportunities to affect change. We can potentially have interventions in each one of these cells. So I want to just simply, and I also want to note that it's hoped that this framework can allow us to systematically identify, test, and evaluate potential solutions that can accelerate progress in this area. And this can hopefully illustrate untapped opportunities to significantly influence population health, many of which are not adequately addressed in national public health discourse or strategies today. So I want to just simply close by asking you to imagine that there's a new drug on the market and it's freely available. So it would increase survival by as much as 50%, reduce risk for cardiovascular disease by 29%, reduce risk by stroke by 32%. It not only reduces the risk for developing new depression, it also can reduce the severity of depression. It reduces the likelihood of developing dementia, and can increase your immune response, making you less susceptible to cold and flu viruses. And better yet, it comes with few, if any, side effects, and actually increases well-being. Now, of course, what I'm talking about is social connection here, but if this were a new drug, everyone would want a prescription to this. Everyone would want to use this and invest in this drug. And so what I simply want to close with is I hope that we all can be equally as invested in our social connection. So thank you.
Professor Holt-Lunstadt, thank you very much for your comprehensive and excellent presentation, and for what you are doing in the research field to help the better comprehension and the better solution for this problem. Now we go directly from theory to practice. And we talk about social prescribing and how we can counteract this problem in the community. And we have a special testimonial for this, Dr. Cristiano Figueiredo, who I'm going to present. Cristiano Figueiredo is a family doctor at the Baixa Family Health Unit of the São José local health unit in Lisbon. He is the co-founder and co-coordinator of the first social prescribing project in Portugal and of the Social Prescribing Portugal network. He is lecturer at Nova National School of Public Health, Nova University Lisbon, a PhD candidate in public health, specializing in health promotion, and co-author of scientific articles, courses, and other publications dedicated to social prescribing. So, Cristiano, the floor is yours. Please, come.
So thank you very much for the introduction, very kind. And so my goal today is to bring you a very practical view of this journey of implementing social prescribing in Lisbon, Portugal. And yeah, it's working. So it's really a first-person testimonial, and this is what happened in the previous 8 years in my daily work. But above all, I want you to know that I'm a really everyday family doctor and who provides primary health care. So my day-to-day basis is providing consultations, about 40 hours per week. And in the meanwhile, I was able to introduce this social prescribing idea and to find time and the people and the energy to bring this into practice. It's also very interesting to know that family doctors have a big connection with their communities. They follow their patients for their life course, so from birth till death. And maybe they are in a very important position to bring change in their communities. And that's what I will prove to you and what I have done. And of course, my patients don't know me because of social prescribing. They know me because I'm their doctor, okay? I'm their, when they get sick or when they need some kind of advice, they'll come to me, okay? So let's start with this bridge. I guess you know where is it? It's in London. And the reason for that is all of this journey started in 2015, so 10 years ago, when I went on a Hippocrates exchange, Erasmus Plus exchange in London. It was only 2 weeks, but during these 2 weeks in Lisbon, I get to know a different way to work in primary health care, more connected to the community. How to get out of your office and speak with the people, speak with the local organizations, and speak also with the health leaders to bring change. Also, in this exchange, I was able to meet someone who was introducing social prescribing in one area of London. His name is Patrick Hutt, and he was the clinical lead of social prescribing project in Acne and City CCG, they call it. And the first time I heard about social prescribing, I was, what's social prescribing? It was very new to me. And I started looking for papers, researches, reports that were addressing this very curious name, social prescribing. And it really captivated me because I thought it was bringing something new to medicine that was necessary. And back then, I was a very young family medicine resident, so I was really in the beginning of my career. So in the same year, this research was published, and they were surveying about 1,000 GPs, family doctors in the UK, and they found that about 20% of their consultation time is dedicated to non-medical issues, to social factors, including, of course, social isolation or personal relationship problems, and all of these reasons you can see on the right side of the screen, all of these reasons that were part of discussion of the consultation. And you may think like, okay, is it really the role of the family doctor to address these issues? Does he have the time for that? And you'll see that in this survey, some doctors are saying that this is very relevant to me because getting this information, I know better my patients so I can treat them better. I can make a plan better for them. But also some other doctors were saying that, well, this brings a lot of pressure to my work. I don't have the time, I don't have the energy. If I'm speaking about this with my patient, I'm not providing health care to other patients, okay? So there are different views. The next year, it was 2016, it was the first year when social prescribing was defined. There was a first conference in London, and social prescribing was defined as a means of enabling GPs, family doctors, and other frontline healthcare professionals to refer patients to a link worker, to provide them with face-to-face conversation during which they can learn about possibilities and design their own personalized solutions. Example given, co-produce their social prescription, so that people with social, emotional, or practical needs are empowered to find solutions which will improve their health and well-being, often using service provided by the voluntary and community sector. It's a very long definition, but I think you get the idea. This was 9 years ago. And now let's go to Lisbon. So starting social prescribing was really like constructing a bridge, building a bridge from start. Two areas were kind of separated, and it was necessary to make them together. So this is the Baixa Family Health Unit. It serves about 16,000 patients in downtown Lisbon, in the most historical neighborhoods. Also, these neighborhoods are famous because of a big migrant population, mostly from South Asia, India, Bangladesh, Nepal, and because of lots of tourism pressure. And hopefully you had the chance to visit Lisbon, and you are contributing to this. We need tourists, of course, but this also brings pressure on the historical neighborhoods as people are moving out of these neighborhoods to more suburban areas. It happens also that people who live in the neighborhood where I work, in Santa Maria Maior neighborhood, people there live actually much less than people in the north side of the city. So when you take the blue line metro from Sete Rios, nearby to the zoo, down to the river, to Santa Maria Maior, you are decreasing your life expectancy about 6 years. And this is not because of bad access to primary health care, to hospitals, or bad quality of care. It's mostly because of their social conditions, what you call the social determinants of health. So maybe this information is not new to you, considering this course, but only 20% of the health outcomes of our patients depend on the quality and access to healthcare. And about 40% of their social economic factors like education, income, family support, 30% related to health behaviors like smoking, drinking, drugs, exercise and diet. And as doctors, we very likely we will approach this subject of the lifestyle factors, but not so much the social economical factors or the physical environment. And so this brings me to say that health is made at home, and hospitals are for repairs. And if you have the chance to visit Lisbon, that's where I work, in this place, okay? In this square. Okay, just knock on the door. I will host you. So let's bring you some very precise stories of our kind of patients. So Abiba is a 23 years old Bangladeshi immigrant. She's in Portugal for 9 months, 20 weeks pregnant, and she doesn't speak English. Her husband works all day. She has no friends or family in Lisbon, and she feels lonely at home. José is a 75 years old man, lives in Alfama with his wife. He has several chronic diseases. Most of the neighbors, the younger ones that were not protected by law, were evicted because of tourism and Airbnb pressure. His sons are living far away, the rest of the family is living far away, and he spends the day watching TV. And when he comes to my consultation, he's concerned about memory, and he feels without a purpose. You can see that. And then Paulo is 56 years old, is unemployed for 4 years, so quite long unemployment history, divorced, living in a rented room supported by some kind of charity. Is obese and is getting worse, his weight, and is increasingly anxious during the consultations. And I know these people for over time. And he's also feeling low mood. So I'm asking you, what do you think is the solution for these problems? What kind of problems can you find here? Do you think this is the necessary solution? Not yet. Probably not yet, okay? Not yet. So now getting back to my family doctor role. So what can I do as a family doctor? How can I improve my patients' health-related social needs? So everything that is having a big impact on the health and well-being of my patients, but is not medically concerned, like the social needs, okay, like social isolation, as he spoke. And why should I take care about this? And I think it's always a good time to remember what is the physician pledge, okay? The health and well-being of my patient will be my first consideration. So when I know that 80% of the health outcomes of my patients don't depend on me, should I actually try to approach them? Should I do something about the 80%? Or should I be just in my 20% cohort group? I was thinking about this, and let's start. So everything started 2017 with two people who decided to give it a try. Me as a family doctor and Andrea Coelho as a social worker based in primary health care. She never heard about the topic social prescribing, but she was very curious about the possibilities that it created. We invited all the local stakeholders to share their needs and resources. So we had the first public meeting inviting everyone, like, we have a meeting to introduce social prescribing and we want to listen what you have to say about it. Health sector leaders, community sector, municipality, NGOs, local associations, everyone were invited. And suddenly you find out that we are kind of needing of each other, but we are not communicating, we are not collaborating. And probably we had the solutions for each other's problems. So it was very easy to pick apple, okay? Very low. And social prescribing implementation is truly a complex, multidisciplinary, intersectoral, and continuous process. We should always start with the patients, okay? We should always think what our patients need, okay? Then you have to engage with in the academic field, we speak about the social prescribing link workers, someone that will make the connection between the health sector and the community sector, and that will have enough time to address these social issues. So in our case, in our country, what makes sense were to invite social workers to join the project. So to motivate them to have this kind of extra work and extra responsibility with the social prescribing. Of course, it was necessary to engage as well with the primary health care team. So how to convince family doctors and nurses to actually recruit patients for social prescribing, to address these issues during their consultations. And I was very happy to find out that my team was very open to it, okay? And I would say that most of the teams are very open to it as long as you organize it in a practical way that is feasible, something that they can identify easily the patient and refer to someone who will take care of the issue, okay? So digital solutions are important in this field. Also, it was necessary to engage with health leaders. Like, I started studying medicine 20 years ago. So that's 20 years ago I started studying medicine. I'm a family doctor for almost 10 years, okay? And I always feel that we are living crisis after crisis. In Portugal, we feel this, like not enough doctors, long waiting times, more and more demand from the patients. So it's crisis and crisis after crisis. And suddenly you have someone who is saying, okay, maybe the solution is social prescribing. Let's make patients, let's connect patients to the community. And many of the health leaders will be like, but we have more severe crises to solve. We have more important stuff to do. So it's kind of difficult to get into them. But you can do it. You can do it. It was also necessary to engage with lots of social partners. So these social partners were from the third sector, local associations, like charities, like municipalities, the small parishes. Everyone were invited. And you were doing these very regular meetings at the community where everyone could have a say about something, okay, and share their solutions to the problems that we are facing in our community and also feeling that in our consultations. Academia. Soon I understood that as it was something very new in Portugal, I needed to invite academia to do research on it and to evaluate. And this is still going on, okay? And it was quite essential because it kind of gave some framework and some responsibility to what we were providing. And also sharing the knowledge is quite important, not only locally, like in Portugal, but also internationally. There was also lots of work on engaging with other health professionals everywhere. So a lot of social media work with Facebook pages, trying to get other people to know about social prescribing and to start kind of a movement. And of course, engaging with the media. Something that I discovered, the media love this topic, okay? Journalists are very captivated by this topic. And they think it's something very obvious. And why is this not part of the normal healthcare? And they really find curious when someone tries to implement it and delivers it. And just before I came to stage, I had another national magazine from Portugal asking me to do an interview on this. So this is coming very regular, and I always trying to share this. I always try to share this focus on other people, like inviting social workers to speak, the patients to speak, other colleagues to speak, so that it is not one-person movement. And maybe our highest point was when the national TV channel SIC made a 30 minutes reportage about social prescribing in Portugal, and this happened in April this year, and it was quite important. On a Sunday evening, it was quite big. And don't forget the patients. And these ones are probably the ones that are the hardest ones to engage, okay? For many reasons. Many times they are not organized in associations or in patient participation groups. And it's really important to try to get their voices, even though they don't take the step further to communicate. So we integrated social prescribing referral into the electronic health record in a quite kind of easy way, so that doctors can, in their consultations, just identify the problems they found, like social isolation, problems with migrant integration, low physical activity, housing issues, employment issues. So they can very easily select what are the social issues that should be addressed by the social worker. And on the right side, you have also the kind of solutions we can offer in our community. So they can introduce to the patient what will happen next. And this creates kind of an email that brings into the discussion family doctor, the family nurse, the social worker, that will allow the follow-up of the case and to provide some feedback about what happened after the referral. We met our third sector and local authority partners every month. So this was very important in the beginning, like inviting everyone to design the project, and so that we'll agree on the way we're working on the governance of the project. And we were doing a lot of visits to our third sector partners, and also it was very interesting to see that the health professionals were getting to know different third sector organizations, and they were visiting them, and this was very interesting. But also the third sector organizations were meeting each other, and suddenly they were collaborating more because of this. We helped the third sector to launch new initiatives with funding. So what you can see on your left is a pregnancy club we started for South Asian women, with supporting a migrant association to apply to some funding. On the middle is like a healthy cooking workshop. There is like a local kitchen, local community kitchen. They provide cooking workshops, and we help them to apply for some funding where they would provide some workshops for healthy cooking, always taking into consideration the different cultural aspects of eating and flavors, because we have about 30% of migrants in our community. And on the right also we support another organization, Cycling Without Age, to apply to some funding. What they do some riding. They ride with people that, usually elderly people or people with some problems moving, walking. They do some tours around the town, and there is always a volunteer who will speak with the person, and this becomes kind of fun for the people. Also, we gave voice to our patients who shared their stories in the media. So it's very easy to find patients' testimonies on the impact of social prescribing in their lives, and you get all sorts of patients, and really everyone learn a lot about these stories. I learn a lot from my patients when they tell me what happens afterwards, after my referral. So nowadays, social prescribing Lisbon is a program that is implemented within the local health unit of San Jose. We have many of third sector and municipality partners, and of course you have the support the academia, and is centered in the person that is here right in the center. So nowadays the patient goes to the primary care professional, family doctor, let's say. He may like introduce some social issue. Maybe the patient brings it himself, or is the doctor will actually address this, like do you live alone, or do you do any physical activity, do you engage with arts and culture, whatever. Then they will propose a referral to a social worker that is based in primary health care, is paid by the local health unit, and is based in primary health care. She works really next to me. And also the patient can directly access the social worker. And then after this half an hour meeting, she will propose and co-produce with the patient a social prescription that will take use of many community resources that can be direct, like Tai Chi classes, or Portuguese language courses for migrants, healthy cooking workshops, gardening at the botanical garden, or visiting some art exhibitions. So let's go back to these stories. So for Abiba, we could offer some mentorship program for migrants where they meet someone from local that will kind of guide them into integration into the Portuguese society, like a mentor. She could be referred to language courses in Renovar Moraria, or to join that pregnancy club. For Senhor José, he could join a third age university. I don't know if you call it like this in Portugal, in Switzerland. It's like a group of, like a university, a group that usually above 55, that gets together to learn different stuff. Usually it's based in the community. It can be arts, can be languages, anything, sports. So we have these offered by the local municipality. You could also be referred to a kind of a day center, or go for the first time to the theater. For Senhor Paulo, to join some exercise program based in the community for people higher than 55 years old. You could join some botanical gardening in the local botanical garden, or go with the cycling without age tour. And looks quite far apart, like a medical prescription on site, social prescription the other side. But truly, this is deeply connected, and it's common sense. There is no reason this is not connected nowadays. You have the evidence, you should get it into practice, and hopefully it will not take more than 17 years. So this is what we have now. 8 years later, we continue to meet with our partners in the community on a regular basis, so we're still having this meeting approach. This was like last month. We continue to support the development and financing of new resources in the community. This is like a new project that was started by a local garden, and they do many things related with gardening. It's community-based. They also have a chorus to sing together in that garden, and it's a really beautiful project we got to discover, and we are supporting them. We continue to go out of the box looking for new solutions to the needs of our patients. So many of our patients who are socially isolated, they don't want to leave home. They don't really want. So an easy way to start is to provide this kit. These are monthly kits that with art-related activities, something to do on their self. And they can start doing that with some guidance. Also, they can get together in specific points to do it together. And is kind of a starting point for having some social connection for some people. We continue to test new cultural prescriptions, taking advantage of free access to national museums and monuments. So last year, the Ministry of Culture decided that every citizen in Portugal can have access to certain visits per year of monuments and museums. And we did this kind of plan of high intensivity cultural prescription, like once a week, then the low, more soft way, like once a month, where people will commit with their doctor and social worker to visit certain local monuments in the Lisbon region. We continue to share our knowledge and to learn from the experience. You will find many papers based on our work in Lisbon. Okay, and this evidence is still being created. And we continue to make history and to inspire the transformation of other health systems. As you mentioned before, this was one of the first projects that happened outside the UK in a very specific way, in a very bottom-up approach, grassroots movements, and it's very beautiful to see that this project that started with 2 people getting other people involved suddenly is being shared in all of these publications and inspiring others. We continue to revolutionize the primary health care, integrating social prescribing concepts into a new healthcare buildings. This is a healthcare center in nearby Lisbon that was designed by an architect, a friend of mine, who trying to include some of the social prescribing concepts of meeting and gardens and greenery. So it's a nice place. So we continue to prove that social prescribing is possible. It's not an impossible cube, it's possible. It's more like a Rubik's Cube. You just need to twist our reality and find a way to make it work. Medicine is the social science and politics is nothing but medicine on a larger scale, is a famous statement. This is the timeline in Portugal. 2018, it was in the first patient being referred to social prescribing in Lisbon. 2019, it was the winner of the Sustainable Healthcare Award, a national award for health innovation. In 2021, it got a little bit into politics with Portuguese Parliament and the Health Parliament Portugal recommending it, but then the government collapsed and it started from zero, this kind of recommendation. 2022, we had the EuroHealth.net visit to our project. 2023, third sector organizations and municipalities start taking the lead on implementation of social prescribing in Portugal. 2024, it was the launch of social prescribing in Portugal network, and this year there was the Lisbon and north of Portugal. It's like a regional body that is responsible for funding and politics, sign contracts to implement social prescribing. So nowadays you have many initiatives in Portugal and is spread all over the country. And you have like initiatives that are promoted by the health units, others by the municipalities, like mayors, others that are promoted by the academia, and also for third sector organizations. So you have different models of governance nowadays. So tomorrow, social prescribing in the national service in Portugal should look like this. We need for sure more social workers, more social prescribers. And I always say, for this, you need more money, okay? So what we find, the way you start the project was using the resources already in the system, but you are creating kind of a new need, a new solution, and you need to have enough resources to address this. Also, for sure, we need more community resources. There is no social prescribing without a rich community, a thriving community, and for this, we need money. Of course, you will get more patients. The population is increasing in Portugal, at least. Also, people are with more chronic conditions, more pressure on the health system. We need, for sure, more health professionals. And for this, also, we need money. You have a big lack of family doctors in the Lisbon area. This is a big issue. Probably also happens the same in Switzerland. We need as well more monitoring, evaluation, more digitalization of the project. For this, of course, we need lots of money, lots. But yeah, we are hoping for it. And just to finish, I have presented social prescribing to each of these personalities in private and face-to-face meetings. I'm very lucky to work in a primary healthcare center that is very central in Lisbon. So when there is any visit, like a big figure, some big personality, they will select our family health unit to visit. Okay, so I had the chance to present social prescribing to everyone you can see in this picture. But really, what I believe that social prescribing is a grassroots movement, bottom-up movement that can start with everyday student, everyday doctor, everyday nurse, everyday social worker, everyday patient, everyday citizen, who believes in the future of social prescribing in Lugano, in Switzerland. So it's up to you what we will do with this information. Thank you.
Okay. Cristiano, thanks a lot for your passion and enthusiasm, for your work in your mission to make a real revolution, how to change the general practitioner way of working. So it's really a historical revolution. So now we have some time, not too much, for question and answer. So discussion is open.
Thank you a lot for your presentation, Cristiano. I wanted to ask you, when you have patients that have a physical issue where you have the sense that social prescribing could be also a treatment, how do you tackle the conversations? Which questions do you ask? And how do you overcome their maybe initial resistance to convince them to participate?
Is it working? Yeah. So, that comes with a physical issue?
Yes.
Physical issue, okay. So, more commonly, social prescribing, we connect social prescribing with mental health issues and social issues. But also, it's a way to address the physical health somehow, because most of these activities will make the people to move more and to be more active. So it's not only about meeting people, you need to be active to meet people. You need to be active to go to museums, you need to walk, at least walk. So I'll say that even though only a short portion of referrals to social prescribing is for the reason of physical activity, to access physical activity in the neighborhood, most of the social prescriptions happening actually make people more active. About how to address when the patient is not really into it. Okay, so first the patient needs to recognize this as a problem. Okay, and he should work on this. Okay, and many people don't recognize being lonely as a problem, or many people don't recognize being physically inactive as a problem. Okay, because they feel good, they are able to do their stuff, and probably it's not their priority. So I think what really helps is the continuity of care. So the fact that you know the patient for a long time, so it won't be the first time you meet the patient. And even if the patient in the first time is not really up to it, is not open to it, you can ask again in next visit. So and the patient will have enough time to think about it and to see if they would like to give it an opportunity. So person-centered care, continuity of care, and also always try to find something that the person really likes. Okay, so I will ask what you used to do, like thinking about physical activity. What do you used to do when you were younger? What gave you pleasure when you're physically active? What do you miss? And when you go through these memories that brings joy to the person, probably the person will be more happy to try something new again.
Okay. Thank you very much.
Other question?
May I add something to that response?
Absolutely, yes.
So we often see most of the social prescribing happening associated with mental health and, as he talked about and related to physical activity. We actually have very good evidence that when it is used and integrated into physical health treatment, it is quite effective. So for instance, I did a meta-analysis of 106 randomized controlled trials where some kind of psychosocial support was provided to patients being treated in clinical settings. So oftentimes hospital settings for treatment for heart disease, cancer, stroke, type 2 diabetes, other kinds of conditions. And what the analysis found was that when this support was provided to patients, that this increased survival by 20%. So it is related to physical health. And so, we need to think about this across both physical and mental health.
Okay. Professor Holt-Lunstadt, I have a question for you. I understood from your presentation that the mortality risk is higher for social isolation than for loneliness. What could be the explanation?
Yeah, so while both loneliness and objective isolation are both independently associated with mortality, not only is the effect size stronger for objective isolation, but this is also independent of loneliness. So meaning that even if someone is isolated, or even if they don't feel, or regardless of level of loneliness, objective isolation increases that risk. And so part of that is that isolation can be linked to not only the, so while loneliness is more the subjective and might be more associated with the kinds of emotional kinds of effects, isolation may be linked to more behavioral, it can link to both emotional and behavioral kinds of outcomes. And so, for instance, if someone's more isolated, they may be health-related kinds of behaviors, may be poorer. We also know that, for instance, if someone's living alone, although that doesn't necessarily mean someone's isolated, but oftentimes that is a marker of isolation. If people aren't around in a crisis to call for emergency help, that can be a matter of life and death. If someone falls and others aren't around, again, that can be problematic. But we also have good evidence of the biological effects of when you are in isolation, how your brain needs to be more active to, in essence, meet the demands of everyday life on your own. And so that is taxing on our physiology. And so that over time can have dysregulating effects that can increase our risk for earlier death as well.
Okay, thank you. Thanks very much. Cristiano, se ci sono domande, prego. You had to convince a lot of people to come on board in your mission. But what was the most difficult thing? To convince other doctors, to convince social people to become a social worker, to convince politicians, to convince patients. What was the most difficult part?
So I think the easiest ones to convince were the doctors.
The doctors.
Yeah,
I suspected.
Because they really feel it in their daily practice, and they really they really feel they need this tool, they need this kind of support. Mostly when they work in deprived areas, like in poorer areas or where people live more alone. Okay, they really feel this. About politicians, it was a bit difficult because you were asking the data, okay, can you prove that this is worth it? But they were not providing the resources to make this work. So it's like they are more focused on the results, but not really on what actually did you give to us that allow us to implement it. What kind of resources did you actually? And this becomes a bit difficult because I can bring international evidence that is getting more and more robust, but still we need more research on the topic. Yes. But most of the times politicians want like local research or local evidence, and it's difficult to bring it without enough funding for the implementation. I would say that one of the big issues was with social workers.
Social workers.
Yeah, social workers, because I don't know, there was a lot of misunderstanding. They were somehow thinking that doctors were taking their role in the beginning, like doctors that wanted to address these social issues, and they felt a little bit threatened by this. Even though I was always saying, explaining that this is just promoting team collaboration between professions, that we'll have a doctor or nurse will be more cautious and more attentive to these issues, and will refer the patient for them. But there was a lot of misunderstanding on this, and it's still an issue in Portugal. Are really the social workers ready to be social prescribers or link workers? Do they have enough training? They have the right motivation? It's still a big issue. About patients, I would say that it takes time. It takes time. We need lots of campaign and education for that.
Okay. Thank you. Other question? There is one question. No, two questions. First and second, okay.
I try to make my question in English, not exercise. What about developing or using a special approach to communicate with the patient? I mean, doctors, not every doctor is keen or ready to speak with the patient about his needs. I'm running a project for prevention and health promotion in medical care. This was the first problem we have to face. That is, doctors say that they are there to care, to cure the patients, not to care about the patients. That means they just provide medical advices and services. So we introduced I'm sorry, the motivational interviewing as a tool for speaking, for modifying the relation and the communication with the patients. What do you think about this? And don't you think it is something really essential for entering into the right relation with the patient and for really hearing their deep needs and not only their problems?
So I will try to answer the best I can. So I think the doctor-patient relationship here is very important, okay? And part of this relationship is due to good communication between both parts, and to be very honest and very frank, collaborative on same level, and also be very respectful for different positions. Sometimes the doctor sees the need for that, but the patient doesn't see it, and you have to respect, and you have to work on this motivation. I'll say that most doctors don't have training on motivational interviewing techniques. Nowadays, probably newer doctors, newer generations are getting trained on this. But we know from the evidence in social prescribing that this is essential, mostly, at least in the link worker level, in this level of the person between the health sector and the community sector. This is very, very important. For sure, it's important to train doctors and new and ongoing doctors to improve their communication skills, including motivational interviewing. Also, you can kind of build a system that will help these kind of difficult conversations to start. One of these ideas, it comes from US actually. So you have like the American Academy of Family Physicians and different organizations, they are promoting the screening of health-related social needs. So there's some screening tool that they will, imagine a patient registers in the family doctor, they'll get a screening, like a survey, to answer a few questions about their life conditions, being lonely, social isolated, physically active, housing problems, financial problems. And maybe with this information, having the family doctor getting this information when meets the patient, maybe it would help to start the discussion. That's another way to address the issue.
For example, the 3 items.
May I add to that as well?
Yes.
Yeah.
Oh, go ahead. I was just going to say, we also have data from the U.S. that the majority of physicians still view this as a mental health issue, and so there needs to be a lot more education that this actually is relevant to patient health outcomes. And so part of that is helping to, as part of the training, to recognize the role of social connections, isolation and loneliness, to treatment, to the development and progression of disease. We have very good evidence on this. But further in research, we found that there are incredible barriers, even among those that are aware of the importance of this for their patients' health and treatment outcomes, that there are real barriers in terms of the kinds of resources and support that are provided. So many feel like they simply don't have what they need. And the biggest barrier that came out was not enough time. And so what we really also need to ensure is that healthcare providers have the adequate time, resources, and training in order to actually adequately address this.
Okay.
Agree.
There was another question. A short question because we are running out of time.
Yes, it will be a short question. Thank you. I would like to ask Dr. Holt-Lunstadt. You mentioned when you were talking about the meta-analysis that social connection increases the rate for survival by 50%. I'm curious to know, like, if there is any evidence of how expanded the social connection should be to bring such an outcome, or, in other words, like, what is assumed to be appropriately socially connected individual? Thank you.
Nice question.
Yeah, excellent question. So, of course, you can find the details of this in the meta-analysis, but we had a broad inclusion criteria, and so it really looked at a variety of ways in which social connection has been measured, and that helped to establish that those 3 core pillars in terms of how it was measured across different studies. And so that represents an aggregate across these different ways of assessing that. And then the bar chart that I provided also gives some breakdown in terms of how that has been assessed. And so what these studies show is, and so when we look at it, we look at the structural kinds of indicators, the functional indicators, and the quality indicators, all of which are significant. But at a meta-analysis that is at an aggregate level, and we did find that complex measures of social integration, similar to the so one illustrative assessment of that is the Berkman-Sign Social Network Index. That was the strongest predictor of mortality, and that looks at complex levels.
Okay, thanks. I think that now we have to close the evening because it's the usual time in which we stop. I want to thank, first of all, the speakers for their brilliant presentations. An applause. Thanks to the translators for their precious work. And adesso torno a parlare in italiano per presentare l'ultima lezione. È qui, è già, la diapositiva c'è già. Allora, non perdetevi l'ultimo incontro, perché vedrete come si sta preparando, anzi ci si è già preparati, ma è già una realtà, un progetto che sta portando questa filosofia nuova della prescrizione sociale in Lugano. E quindi avremo il professor Luca Gabutti che ce ne parlerà, spiegherà cos'è questo progetto. Prima di lui ci sarà Jess Bone, che è una ricercatrice del University College of London, e racconterà un po' il modello anglosassone, il modello del Regno Unito, che è partito 30 anni fa, più o meno, e ha fatto scuola. Quindi lei ci porterà anche delle informazioni su quello che hanno consentito le ricerche condotte da loro in questo campo, e credo sarà molto interessante. Poi un'altra particolarità, che magari non è del tutto irrilevante, al termine di questo incontro, generosamente la Fondazione IPSA ha preparato un rinfresco per tutti voi che sarete presenti, quindi una ragione in più per non mancare questo incontro. Allora vi saluto e buona serata a tutti, grazie della partecipazione.